We're going to rearrange the agenda and start with number 6 on the diabetes. But first, let's do the introductions. Welcome to committee members and members of the public to the South West London CCG Collaborative Decision-Making Committees in Common meeting in public. Please note that this meeting is being filmed for uploading onto the South West London CCG websites. Should any member of the public not wish to be in the video, please see one of the administrators at the back of the room. Housekeeping notices. There are no scheduled fire tests for today, so if the fire alarm goes off, the fire exits are here and around the corner. Facilities are around the corner, male and female. There's an acronym buster glossary available, which newcomers may wish to make use of. And a copy of the Declaration of Interest Register is also available in everyone's papers. Apologies have been received from Lucy Walters, who's the Managing Director of Sutton CCG, and Michelle Rahman is taking her place tonight. We are one short of being quorate at the moment. We need another lay member from Croydon to be quorate, and I believe we will be soon, but we will start shifting the agenda. Oh, sorry, one further thing. Declarations of interest. Members are asked to declare any interest not already on the register of interests and or to declare any interests rising from the agenda or papers presented to the meeting today. So if you feel you are conflicted, have a conflict at the start, please raise your hand and say so. So we're going now to the new number 6, the new diabetes glucose monitoring system. And this is for information. Sarah Taylor?
So, shall I?
Yeah.
Hang on. It's all right, I wasn't ready for that item, even though I said let's do it. So this is for information, this item, and it's actually been discussed at all of the CCGs and agreed by all of the CCGs for South West London. And it's a pilot that's been recommended by the Regional Medicines Management Optimisation Committee for London. And we are implementing that across South West London according to the criteria that the Medicines Optimisation Group have put forward to us. So what we're just making sure here is that everybody has sight of what we're doing across South West London, and a few of the things that have been brought up in discussions with members when we've actually implemented this or talked about this in different CCGs has been about making sure that we, number one, have a good way of reviewing this going forwards, and that we work with the Regional Medicines Optimisation Committee to make sure that that is covered, and that we make sure that the information is given to general practice in a way that makes sense and they are supported in order to implement this. So I wasn't going to say too much more than that, because I think most people have seen the paper and it's been discussed at CCG level, but I asked Sarah to come along today, so if there are any sort of very detailed technical questions, she wrote the paper and she can come up and answer those for us. Is that okay, Sarah? Lovely, thank you.
Right. Do we have any questions or comments? Yes.
It was just one thing on the implementation on I think it's the 5th page in bullet point 2. Specialist centre are to provide an annual update in usual appointment clinic that patient is benefiting from Freestyle Libre and should continue. I think we know what it means, but I'm not quite sure that that really makes sense.
So Do you want to come up, Sarah? Do you mind? Sit next to Jonathan here and put the microphone on.
Hello, Sarah.
Hello, hi, thank you. So Les, just to clarify that the intention with implementing this guidance is that actually no new appointments are necessary. So the whole point of the annual review is that actually this is a review that should be happening anyway, and that the review should be happening as part of that additional capacity is not needed in order to undertake that. And as part of that process, there's various criteria that the patient needs to meet in order to continue with treatment, and those will all be assessed and that information provided back to the GP to support ongoing prescribing.
Can I ask that then is perhaps rephrased to make that slightly clearer?
It's probably clearer in the original documentation, in the actual supporting documentation that comes from the clinicians in the hospital to the GPs.
Okay. Thank you.
We had something raised at our AGM around people who are already on it because they've been funding it themselves, and because of it's successful, their HbA1c has dropped down below the eligibility criteria, and then they wouldn't be eligible for it to be funded on the NHS. Has that been acknowledged, and are we making sure that people don't end up tripping up because of that? So
the process is the same for all patients, regardless of whether they've been self-funding originally or whether they're new patients, in that the treatment will be overseen by the hospitals. The assessment criteria will be as if they were started from new. So it won't be that your HbA1c has to drop further to continue. It will be assessed from the start of treatment to the point that we're at now, so that they won't be disadvantaged.
So you'll take the HbA1c readings from before they started on it themselves, yeah? Okay.
Yeah, because that's what they're based. They're using the true baseline, not baseline after 18 months of treatment or something.
I think just building on that point, I think that would be very helpful in terms of any patient guidance and any clinician guidance, because that certainly hasn't been the understanding that some type 1s have had. Some type 1s who were poorly controlled and self-funded to get controlled have believed that because they're now controlled that will be the baseline reading sort of post self-funding control. So I certainly think some clarification in the guidance would be really helpful on that.
So that's not my understanding, but I will take it back and get some clarity on that.
Any further comments or questions? So we've had this presented for information, and we'll have confirmation of answers to the questions. Thank you very much. We'll now move back to the agenda as it's printed and go back to number 3, the health-based place of safety business case, and this is for approval.
Sorry,
You caught your breath.
Sorry, apologies for being late. Traffic from Richmond. Yes, the committee's been asked to approve the proposal for a single-site adult health place base of safety in South West London. Just for clarity, this is around the physical health place base of safety site in South West London, which is based at Springfield, and that really serves the 5 CCGs who commission secondary mental health services from South West London and St George's. Croydon commissioned secondary mental health services from South London and the Maudsley SLAM, and obviously their health place base of safety, their pathways are into the SLAM and Oxy's provision. So we are really today considering the single physical site in South West London, but acknowledging the Croydon, and I know Croydon are involved in the conversations on South East London side about the development of the health place based safety site, that side. I'm not going to go through the presentation in detail. I just thought I'd highlight a few areas for you. There have been a number of reports over the last 5 years that stress the need to improve mental health crisis services. They're outlined on page 4, and that led to the launch in December 2016 of a London Section 136 pathway, which was endorsed by the Mayor. And actually there is a real strong case for change, supported by the insight from service users. And on page 8, that details some of the comments that London service users have made around the pathway and the provision of health place base of safeties, but particularly for, I believe it's page 8, particularly for South West London in the box, what service users have said. The first point of contact with services seen as vital in situations had escalated where members of staff were unable to de-escalate situations. The health place-based of safety was intimidating and service users didn't always feel safe. Service users didn't always feel listened to by services. Rights under the Mental Health Act and the process for detention were not always communicated to service users. Follow-up care wasn't well coordinated between organisations, and service users had issues accessing support outside of office hours. So even that case for change and the feedback from our service users, a real strong argument that we needed in London and in South West London to improve the 136 pathway. So though it's very pleased that we've had lots of policy and strategy documents focused on that way, we know that our service users are saying that we needed to do better for the mental health crisis pathway, and hence the launch in December 2016 by the Mayor of London around the 136 pathway. But once the launch of the pathway was made, it became very clear that London needs to do a piece of work around focusing on how place-based of safety sites can meet the specification. And the real big change on the specification, the one key component is 24/7 dedicated staff. So previously, health place-based of safety sites have not been staffed by dedicated staff. And we have one very good example in SLAM, where they have moved to a 24/7 staffing model that's proved very successful. I'm pleased to say South West and St George's also have that model, and they use that model with the psychiatric decision unit in Lotus. So an Oxford appraisal was then completed at a London level, highlighting the optimal health place-based of safety site configuration for London, the number of sites, capacity and locations. One of the other, though it wasn't an issue so much in South West London, one of the issues there was lots of health place-based of safety co-located with A&E departments. That wasn't seen to be good practice. So across London, those health place-based of safety sites are being looked into and changed. So page 12 highlights the piece of work that London has done around looking at the optimal number of sites. And the conclusion was that the optimal number for London is 9 across the piece, with 5, 1 in each STP area, being an all-age site. So whilst most of the focus has been around adults, it's recognised that also children and young people need a place of safety, and there is one dedicated site in each STP area for all age, and South West London St George's can cater and manage for all age, so they are our all age site. So 9 sites, that has proved challenging in 3 STP areas. So we've agreed at a London level that we have a transition period from 13 sites to 9, and the 3 STP footprints that I find that a little bit more challenging, I believe, was North West London, South East London and North East London. And that's more about the number of sites they already have, how do they consolidate those numbers down, and how do they meet the 24/7 staffing. So on page 14 really gives us a summary of the configuration of the health place-based safety sites across London, and the highlighted one gives you the proposed option for South West London. So for South West London, we are really not proposing significant change in service configuration. What we are proposing is delivering in full the 136 specification focused on 24/7 staffing. So as I say, what does this mean for South West London? So page 16 starts to talk about South West London. As I say, what we are talking about here is the site at Springfield Hospital. So for Kingston, Merton, Richmond, Sutton and Wandsworth, there will be no change to the existing physical site for the health place-based of safety as it is at Springfield Hospital, and remain there. The section 136 pathway has already changed, and we will continue to ensure that the health place-based of safety at Springfield meets the Pan-London specification. And Croydon, recognising the new specification requirement that anyone can access a health place-based of safety site. Croydon residents will continue to access the Maudsley House Hospital, and we will work closely with South East London to ensure that Croydon is involved in local engagement and decision making on the consolidation of the 2 Oxley sites. So page 19 just gives us the work to date. So you can see in South West London the timeline that we're on. We're at the end of the timeline, particularly around the final specification and engagement with the South West London OSC. We are on track. I should have said at the beginning, this is a process that all of London is going through at the moment, and we are meeting that deadline. And then the next steps, page 21, 22, just summarises the next steps. I think particularly page 22 looks forward. So once we've been through the governance at each STP, we will start developing the local implementation decisions and plans for ensuring that we secure the 136 pathway. That's my whiz through the proposal. As I say, the recommendation being made today is that the committee is being asked to approve the proposal for a single site adult health place of safety at Springfield Hospital. Happy to take any questions.
Thank you very much, Tanya. Do we have any questions, Andrew?
So I understand we're not being asked to change the number of sites. I guess what I wasn't quite clear about is where are we at in the process of getting to an ideal Section 136 pathway? So how far are we from where we think we should be? So the case for change comments, which some of them look not great, was that case for change before we started implementing the changes, or is there still a lot of work to be done?
So I think there is still a lot of work to be done on the mental health crisis pathway. So Section 136 is a element of the whole mental health crisis pathway, and I think those comments were made at the start of the process. I think we've got much more to do improving that pathway, mental health crisis pathway in general. I think we have seen some significant improvements in the 136 pathway, so we have absolutely seen the reduction in detentions in police cells, for example, both London and nationally. We do have a psychiatric decision unit now at Springfield Hospital that has proved to be successful and has good patient feedback. But we know that we can do more around mental health crisis pathway overall, and we're working through that with our providers and our commissioners, particularly around the presentations in ED. So not every presentation in ED results in a 136 referral, but we know that people are attending ED in mental health crisis, and we need to improve both their experience and their outcomes from that process.
And will we have capacity at the single site at Springfield to deal with all the demand?
So we have done some modelling, and we believe we do have the right capacity, but I do think it's something that we need to monitor closely. So we don't have instance of the suite having to be closed because they're full and can't take capacity. One of the London specifications differences is that previously people were not necessarily admitted to the nearest site where they are experienced their crisis. They were sometimes, if you're away from home, they were transported back locally, units wouldn't take them. The difference is now that you will be admitted to the health place of safety site nearest to where you are experiencing your crisis or you present. But I do think it's an important thing that we keep a real close monitoring on the capacity of the units to be able to meet demand, and we will obviously be in dialogue with the trust to make sure that they are able to manage and cope with the demand. I mean, it's an interesting one. When we do talk to service users, their preference is for the 24/7 staffing rather than distance of travel, because they really see the quality of care with 24/7 staffing. So they're in terms of priority for development, it would be the 24/7 staffing rather than having more standalone understaffed units locally.
As
So you sort of partially answered the question I was going to ask. The patients within South West London will still have access to the health-based place of safeties in other STP areas. So, for example, northwest part of South West London will have access to Northwest London's.
Yeah.
Great, thank you.
Yeah.
Thank you. We had a couple of questions. So we had a query about the capacity issues. I think it's helpful that that's going to be kept an eye on. The other area was, although we're being asked to approve this for adults, there is a need, I think, certainly the Director of Quality at Sutton would like to have more of an understanding about the pathway for children using the suite from a safeguarding perspective and how that works.
So it's fair to say the London piece of work started at adults only, but it became quickly apparent that we needed to look at an all-age approach. And the pathway for children and young people is not as well developed as the adult one. So absolutely, we recognise. I should know. I actually co-sponsor this piece of work at London, so I'm absolutely very conscious of some of these issues. So we know that we need to do better at the children's pathway. I think we have had a discussion around the optimal number of sites, and we do believe one in each STP area is probably the right configuration for young people. One of the challenges we've had at South West London St George's is that the unit, if they take a young person, they have to close down. They can't necessarily take adults. We have had some reconfiguration that unit. They no longer have to close if they have a young person and an adult on the site at the same time. But we need to also work with them and understand the demand. But I absolutely need to do some more work. I'm happy to come and talk to anyone around the pathway and the work we're doing, and if people want to be engaged in that, absolutely.
Tonya, thank you very much for that. That's really helpful and great to know that things are already changing. As it happens, I've just literally come from doing something clinical at Springfield Hospital. I've had to admit someone urgently. I took the opportunity to ask the mental health team there and the social workers, arrangers and admissions. They told me they've seen a real difference in the last 6 months, actually, already from the health-based base of safety that our patients across Wandsworth and Merton have access to. So I want to say thank you very much for that. One concern I think the system has is around the capacity, though, of the acute sector to take patients who are determined by the assessment to then need an acute bed. Because if we can't find a bed for them, they have to stay in the 136 suite or the place of safety suite or the clinical decision unit, which then blocks it from being used by someone else. My question there was, what sort of confidence do we have that our bed modelling is correct to have the beds behind that?
So absolutely we are looking at that, and we actually had an incident with the Trust over the last couple of weeks, and we do treat those as never events. So if anyone overstays the length of stay on a 136 suite, we have that reported and we look into it. And we know we've got some particular issues in things like areas such as female PICU. It's quite difficult to get to bed. There is an ongoing conversation with the Trust around what is the optimal number of mental health inpatient beds, recognising there is a growing demand for mental health secondary care services, but also how do we prevent people needing a bed if we can put more preventative work upstream, because absolutely we want people to access beds, but that's not always the right answer. So it's a conundrum and a piece of work that we are still working on. I'm very pleased to say that we do highlight every breach of length of stay, the 136 suite, and we then do a review of what caused that, and some of it is more around the specialist type of bed that we need, but if there's a general need we will obviously work with the Trust. So I think, but overall we need to make sure we've got the optimal inpatient bed numbers, adult inpatient bed numbers, not just for the 136 but generally the demand. But it is a challenge, but we are continuing to work with the Trust to land that optimal number.
Thank you very much, Tonya. You've clearly put a lot of work into this, and I'm sure we're all grateful. Thank you. We are asked to approve this business case. May I take it that each CCG votes yes? Thank you. Thank you, Tonya. We now move to continuing health care and funded nursing care, equity and choice policy. And, Sarah's doing this one.
Thank you. So I'm doing this on behalf of Lucy Walsh, but I have asked Alison Kirby to come along, who is an expert on this, and obviously I'm not, but I will give you a bit of an overview, and if there are any questions, Alison will help me out on this. So this is a policy that's been running, and it's based on a policy that's been running for around 18 months, I think, in Wandsworth CCG. And it's a policy that is pertinent to somebody that has already been agreed to be funded as continuing healthcare. So it doesn't impact on the decision around continuing healthcare. It's post that decision, and it's around just ensuring that we have a very fair, open and transparent process around making decisions about how we invest our money. It's around the multidisciplinary team, so they work together to identify how we make decisions around placements for people and the best and optimal way of supporting someone whilst also managing what is a financial responsibility of each CCG to use public funds in the most appropriate way. There is no cap on the amount of funding, so within this policy, so that's very important. So there is no financial ceiling, which is a legal requirement for all CCGs, so I think it's important to point that out. This process has been very helpful, I know, in Wandsworth in supporting the staff when they're having to make decisions, and there is always the right for individuals not only to work with the team to make these decisions, but to take it to actually go further if they're not happy with the result of the discussion. So what we're asking today is to approve the policy across South West London. It's worked very well in Wandsworth. We think it's a good policy and it supports the team in their decision making. So that is the proposal, and I'm sure that Alison can speak in detail if anyone has any questions.
Do we have any questions or comments? No? Well,
Is it possible just to hear from Wandsworth, have there been any downsides to the policy? I mean, it sounds like it's working well.
No, I think it's been positive. It's given, as Sarah mentioned, a framework for staff on the ground to operate within. So if there are at times a disagreement with what the CCG believes should be the offer of care to the individual and what the family are wanting for the individual, then it sets the framework of how we make that decision. And then if there continues to be a disagreement, we then set up an exceptions panel, which is chaired by a clinician who's not part of the continuing healthcare team, is part of our quality team. And each case is looked at on a case-by-case, the clinical needs of the patient, how they safely can be met, the costs, and then we do a comparison of what it would cost in each setting of care, so at home or in a residential setting, but using a realistic comparison of those costs. So we benchmark, we use what we usually pay for a nursing home within our local area, but we make sure that would be able to manage the needs of that individual patient. So that will be adjusted to if necessary.
So, Andrew, as you know, that I review every single patient complaint in particular across Wandsworth and Merton CCGs, and Sarah reviews all of them across 5 CCGs. And I think my comment on this process is obviously when you're looking at it from the complaints angle, you only see the exceptions, but what you see from that is that this policy allows us to act with real transparency and objectivity. And actually, in the 18 months that I've been reviewing Wandsworth's complaints, there's, I think, been 2 in relation to the application of this policy. In both circumstances, we were able to really clearly explain the decision-making process of the CCG. So I think that it's, from that perspective, I've seen that it's actually been very helpful in what can be often a very contentious area.
Hi, thanks. I mean, we had just a couple of small points. We are supportive of the paper, but there were a couple of small points under section 13. The first line is firstly, what can I do if I'm not offered these choices? First, you can speak to your GP or healthcare professional. I would suggest that we remove GP on that bit and actually put healthcare professional who is referring you, because that will cover your GP if that's the case. And over the other side of the page, to contact your local clinical commissioning group, ask your GP practice, they'll tell you the contact details. I would suggest that we actually put down the contact details within this document. Is that okay?
Yeah,
Thank
no,
you.
that's helpful, thank you.
Thank you for that. Any further comments or questions? Yes.
So the policy is reviewed by our quality committee and very supportive of it and are recommending to us approval. What we are doing now is looking at the procedures, the internal processes and procedures that support delivery of the policy. So as pointed out from issues of complaints, the policy itself really helps you with that, but you have to have the internal means of delivering it as well. So our medical director is reviewing that at the moment to ensure that not only do we have the right approach to taking decisions, but we are following the right procedures as well.
Thank you. We're asked to approve this. We've discussed it, and may I take it that each CCG is in agreement? Thank you very much. Thank you, Alison. Thank you, Sarah. Thank you, Lucy, who isn't here tonight. Thank you. We move on to item 5, which is commissioning intentions and planning framework, and this is for ratification. Jonathan.
Thank you, Chair. This is for ratification because it won't be a surprise to governing body members. Each of the 6 CCGs will have already considered their commissioning intentions through the course of August and September, and it's really to bring the summary of all that work together in one place as it was submitted to our regulator at the end of September. It's probably worth reminding people what's in the long 76-page document that's set out here. It's both commissioning intentions for programmes of work across the whole of the South West London, commissioning intentions and priorities in each local health and care system, and also contracting intentions, so how we plan to implement some of those commissioning intentions going forward. It is also a strategic document. You have a summary of it that's been tabled here at the meeting. I'm sure, as I say, most of you will have seen a number of pages of this document before, but I thought it might be helpful just to have a summary to present. That, in terms of the commissioning intentions, that sets out what we have to do around our national and statutory duties, what we can expect and need to achieve around our performance standards, how we want to work to integrate services with local health and care partners, how we're going to meet the health needs requirements of the local populations, and how we're going to meet our financial and sustainability duties and responsibilities too. It's really the first step in the process, and the sort of strategic set between July and September, when we set out what we're going to want to achieve and commission through the year ahead. There's now a phase between October and December when we plan that in more detail, and then a delivery phase between January and April when we turn that in to practical implementation and agreed contracts with all our providers. I think it's really important to say there are 3 further influences on the commissioning and planning round this year. Of course, there's your local health and care plans as they get finalised in each local system later this autumn. The 10-year national plan, which we're also expecting later this autumn, and we're also expecting that to be followed by the usual operating planning guidance, which has set out our national expectations. So all those 3 really key pieces of work are still to come, but in terms of setting the scene, this is where we are at this point in time. I'm not going to, the slide deck does go through each borough and what some of the high-level proposals are, and you might want to look at that and compare what you're doing in each boroughs, because I think that's an interesting piece of comparative work that we could potentially do. I thought it just might be worth spending a couple of minutes just so people who haven't had the chance to absorb all the document, are clear about the programmes of work we're doing at scale across South West London. So just to touch on the breadth of that, because I think that's really important. People are aware of that. So to quickly go through those, urgent emergency care is clearly a really major theme through this document, and ensuring people with mental health needs who need access to urgent emergency care get that in a timely way. There's a real focus on primary care, both what we can do to sustain and develop the workforce going forward, how we can provide new ways for patients to access services for improving online access, and how we can use our extended access service, so our GP hubs, better, particularly at evenings and weekends. There's some really important proposals on cancer. South West London remains one of the best performing areas in the country on cancer, and we want to continue to build on that. We have work to do around screening. There's a national bowel screening programme that we're about to implement and help lead the way on, as well as thinking about what diagnostic capacity we need to treat the increasing number of patients who need access to cancer services. Tonya's already touched on mental health, but there's a lot we're going to be doing there on the crisis pathways and community models, which will be familiar to people, but also on perinatal mental health as a new area of priority, and improving access to psychological therapies remains an ongoing priority across the system. I'm sure there are people, as I say, people in the room who can talk to more of the detail than I can if people want to, but it just gives us some idea of the breadth. So the other areas I was going to mention was planned care, particularly in the specialties of musculoskeletal services, ENT and ophthalmology, where there's major pathway redesign, maternity services, where the personalisation and choice agenda continues, but also the work we need to do, as I touched on earlier, around perinatal mental health services and continuity of carer across the patch, learning disability services, getting people out of institutionalised care environments and ensuring the staff are trained appropriately. The extensive work we're doing on children and young people's services to support parents and their families. And also there's sections on continuing health care, personal health budgets and end-of-life care. So that really is at the most high-level whistle-stop tour through the breadth of what is outlined in our commissioning intentions and summarised in the first section. Second section sets out the priorities borough by borough, and the third section talks about how we're practically going to implement it. As I say, I'll finish where I started, which was by saying that this has all been to your governing bodies previously, and it's really just to ensure you see the plan in aggregate, can see what other colleagues and neighbours are doing, and to ratify it, given it's now been submitted.
Thank you, Jonathan. Do we have... Yes, please.
Thank you, Jonathan. I think very, very comprehensive document. And thank you for the shortened summary as well. Thank you. Just a couple, I think, of connected questions. One is around the 10-year plan's going to be out soon. So I don't know the extent to which you've been able, whether there's any insight into what's likely to come that's reflected in here. That's one. And then the second one is, given how comprehensive and large this is, what about the capacity within the CCGs and across the system to actually deliver this?
So I think they're both very fair questions. I mean, in terms of the 10-year plan, I think we're often being asked to contribute as SROs in a particular area in South West London to proposals. So, for example, in cancer, I've been asked for my comments about what's going to go in the 10-year plan. So we're being asked for our views in an engagement type of mode at the moment. I think we won't know how that's all landed until we see the final document published about what that really means, and that's why I flagged it right at the beginning, because that's one of the additional and really important factors we're going to have to consider through this planning round that we didn't have before. So are we engaged in the process? I think we are, perhaps more in some work streams than others, but we are of developing that final plan. But have we seen the final version? No, we haven't, and you wouldn't expect us to until it's published. In terms of capacity, I guess That's partly why I chose to focus on the things we're doing at scale across South West London, because as we've talked about here previously, if we are able to replicate things and do them once at scale, that will help. I think it's a really fair challenge. There's some real breadth and depth to the plans, but of course local systems, and indeed as across the whole of our STP footprint, we need to keep checking in that we've got the right resources focused in the right areas, and that is an ongoing process that we will continue to do on an ongoing basis. Does it reflect the needs and aspirations of our population? I think it largely does, because there's been extensive public engagement as part of it too.
I was very interested, towards the end of the document, you've got some material on a changing approach to the actual contracting arrangements themselves, which I don't think were there when we discussed this earlier in individual CCGs, but clearly it's quite significant, and actually I personally thought very welcome. I wondered if you could just say a little bit about, you know, what's intended here, because it does seem quite a significant change. And secondly, I'd be interested in where we are in terms of discussing these proposals, particularly with the providers, and you know whether these are likely to be welcomed or very difficult, or you know what assessment you have of how successful this will be.
Well, firstly, thank you, Stephen, for getting to page 64, I think, in the documents. So you're right to say that they weren't in the earlier version that the governing bodies would have considered at the beginning of September. And that's largely because we were still doing the work on them at that point in time. I guess the intention is to have greater consistency of how we manage the contracting round and manage our interrelationships with providers wherever possible, and that's the driver behind what's set out here. There's a driver, as the document talks about at length, about doing things together in an integrated way. That is always a challenge in a system that's driven by a payment by results tariff type approach, but we do set out our aspirations as commissioners here. It's a document we've obviously shared with providers. We're starting to receive some early feedback from providers, and we've indeed seen their opening proposal about their provider intentions to us also submitted at the end of September. So I think some of them will be, as we work more together as a system, for example, around managing the urgent emergency care non-elective pressures, will be welcomed, maybe more in some systems than others, but will be welcome, because I think we all recognise across the STP, be we a provider or commissioner, we need to tackle those issues in a different way. We will also try and ensure that this is as locally sensitive as possible, and certainly how we manage the contract. So the Director of Contracting, who currently works in the CSU, is moving across the beginning of next month to report directly into those of us working across the whole STP, and I think they will be involved with managing directors and other senior colleagues in landing contracts at the year end, and that will hopefully allow a greater degree of consistency in what we're seeking to commission and try and achieve. And I think if we act as six, there's also a greater voice that we have with providers when we seek to deliver a service change, which is also a big driver behind why we're doing what we're doing. Does that answer your question, Stephen?
So we don't yet have the forward view, but some of the things that are written in here are definitely what we are hearing as the direction of travel. Clearly, bringing commissioners and providers together in the NHS is one of the areas that will be addressed through the forward view. How can we look differently contractually at how we work together, looking much more at a collaborative model than a split model. And it's about how do we make that happen locally for the benefits of our local populations, because actually we don't want to be spending our money managing contracts. What we want to be doing is spending our money transforming services and delivering the best possible care for our local populations. So we don't yet know what's in it, but we do know that this is the direction of travel, and I think it's right that we flag it. I would say that our providers are actually open to us having those discussions with them and taking that forward. I don't think we're clear yet how we can actually do that sometimes, but I think it's about how do we start to progress that together to understand what's the art of the possible really, and how can we work together in a different way. And a lot of the work that we're doing around our local health and care plans is about how do we make the best use of the total resource that we have in each area, rather than kind of splitting it up into individual service lines. So I think that's the right direction. We will get more information on that coming forwards, but I think it's right to flag it.
Thank you, Sarah. Andrew.
Yeah, so I mean, my question really built on that. It was around the contracting, but particularly in relation to planned care. So there were some tweaks to the contracting process flagged up in here, but I think the conversations we'd been having in our local system, particularly with St George's, were could we go further? And certainly one of the big barriers for us to getting the pathway right for patients and outpatients has been the payment for traditional activity, so the tariff-based system. And I guess the question is there anything we can start to signal at a South West London level about wanting to move away from that? Because we can continue to have the discussions at a local level, but for us to agree a collective position about where we'd like to go would be probably quite helpful. I understand we might not be able to be too specific until we've seen the 10-year forward view, but I do know that at the Clinical Senate we're going to be having a look at planned care, so outpatients, and I expect one of the conversations we will end up having is about how we contract for it differently as well. Will there be time to get something in place and do something significantly different for 1920? That's what I'd be quite keen to know.
James, do you want to come in on this, or Jonathan?
Jonathan.
So I think the document does say that the old or current outpatient model is obsolete, as has previously been signalled. So I think we are saying to providers that we do want to do this in a different way. I think different parts of South West London are in different places on this. I'd be very happy to have some further conversations outside of here about what more we want to go and where we want to push that's aligned with clinical priorities in 1920. I suppose this sets out a degree of ambition, but only a degree of ambition given where we are in the contracting round. If we're able to be really clear and specific about what we can change at pace, that would be really helpful, because then we're in a place that we can get to contractualise that, and that's something that we'll need to do pretty quickly, but very, very keen to do it. Can't answer your question about how far we'll get through this contracting round. I think a lot of that will depend on how relationships have been fostered between providers and commissioners over the last year or two to allow that to happen. And I think it's also worth saying we have tried to put in sort of 3 tiers of joint working between provider and commissioner that perhaps weren't there before, and they are set out in the slide. One at a sort of more technical level with providers and commissioners talking together across South West London, a sort of planning forum, the Finance and Activity Committee that works across South West London, and giving that a clearer remit. And then also the meeting with the chief executives. So Sarah and I and others met the chief executives last Tuesday evening, both of acute and community, etc., and tried to set out, at least in very headline form, these are some of our ambitions for the year ahead. So really keen to have a further conversation, Andrew, about how we bring that to fruition.
James?
Yeah, I mean, as planned care SRO, I'd agree with everything there. I mean, the conversation with Clinical Senate will be one of a number of conversations that we look to have between now and the end of the year about the need to transform the outpatient model. We're doing some analytical work at the moment in terms of the sort of do-nothing case, really, in terms of the demand for outpatient services if we don't transform the model, and what that will mean both in terms of a financial impact, but also in terms of a workforce impact as well, because the workforce impacts are likely to be unsustainable. So I think there's a huge amount of work we need to do to build the case. I think we know that there are elements of the current system that really don't incentivise that transformation, and that works both ways. So it's certainly a conversation that at Merton and Wandsworth level we've started to have with our providers, and I know that it's a conversation that other systems are having as well. I suppose that what we'll need to do is we'll need to agree the approach through 1920 that picks a couple of areas that we can move really quickly on and build some confidence and build from there.
So there's work going on across London actually on this, and I think the chairs met the other day and talked about what's going on around outpatient transformation. Everyone recognises that this is a model that we all want to change. I am sure that we can do some of that reasonably quickly. It's just about, and actually I think there's a real openness from the providers to do that. I think we just need to find a way of doing it. I think that's part of the issue, is how do you make it financially sustainable, workforce sustainable, and deliver the right model. But I think there's a lot more openness now to having those discussions and to thinking through what that might mean. And we do have some examples from other parts of London and other parts of the country that we can start to implement locally. And also I think it's important, it's flagged in our commissioning intentions. If we don't get this sorted for 1st of April, we can still at any point say during the year, actually we'd like to start doing this differently now, and we can do that with the agreement of our providers at any point. So I think there's real potential for us to do it next year. It might not be dead on the 1st of April, but I think with the agreement of the providers and us working together, we have potential to implement something next year that will be really beneficial. Thank you.
My question's partly around process and partly around coordination. If I've understood it, we are being asked to ratify the commissioning intentions, which we have all seen and our teams have discussed, and that's easy. We're also being asked to ratify something which actually is work in progress. So the question is are we actually ratifying this approach here, or are we actually agreeing that it's a good thing to do, which I think we probably all do, but there is a process by which we can coordinate our efforts and make sure we come up with one model or one way of doing it, because the reality is this is quite a profound change in the contracting process. So it's my question, apart from the explanation, forgive me, Jonathan, is what are we being asked to ratify today?
Jonathan?
So I think you're being asked to ratify the full document, because whilst that may be so indeed that's the purpose of testing it here with colleagues, and you've heard the chair of Merton CCG issue a challenge about how we could go further. I think there has been extensive engagement with your teams, so your directors of commissioning, your finance directors have all seen and signed off the approach. It has been discussed with managing directors and accountable officers across South West London too. So I don't think anything in here is whilst the language might be slightly different in some areas, I think it's well aligned with what we're trying to achieve and what we've said we will try and achieve as commissioning organisations. If there is an issue with a particular section, then it would be helpful to know. So I think the answer is, whilst it's been built up from different parts, we're asking people to sign off the whole document, and if there are any concerns about any of the language, then now's the time to flag it whilst we're here collectively, and we can make that amendment collectively. Is that okay?
My main point was one of process. I understand the words you've just used. I have seen in the governing body, I have seen the commissioning intentions. I have not seen the contracting intentions. They may have been discussed with individual members of the management team. I'm not sure we as a governing body have seen this. That's the question. So I can ask my colleagues, but I'm not against it, I'm just talking about making sure we understand the process.
So I think it would be helpful to share if people have not seen that particular section, which may well have missed some governing body dates, because it was. I mean, this is the start of the commissioning process, and it was developed in mid-September, so it would have missed some governing body dates. So I think it would be helpful to share that and then test that with governing bodies, just to check that they are comfortable with the parameters that we've set out there.
Just help clarify.
Okay, of course, Claire.
The contracting intentions section will only, all of the things that are in it won't happen until you actually sign your contracts with your providers. So the second section has been shared with your finance directors, your directors of commissioning, but actually the things in it won't enact until such time as you sign your contract with your providers. So the ratification is for the whole document, but actually there's no risk associated because the second section is developed by your contracting teams. That was written by your contracting teams, and it won't enact until you actually agree CCG by CCG what contracts you sign with your providers, if that helps.
Given that there's several key events still to happen, we're really being asked to ratify the direction of travel on a lot of this. So.
Just to agree with you, Chair, this document is all about a direction of travel. It will only be formalised in the way that Claire has described, and with the other things like the 10-year plan, etc. So it's about a direction of travel. If people think we've misconstrued the direction of travel in some way, then that needs to be articulated. So we do that well. But it is the opening discussion, as it were, as part of the contracting round.
So I think that's right, but it is a document that's been issued. So it has gone out, it is owned, it's owned by the executive teams. It's in the main been addressed through governing bodies, depending on timing issues and so on. And I think it's kind of our statement to the system. And I, certainly from the perspective of the conversations we've had in Croydon, it's very much aligned with the direction we'd wish to go in, as Phil has already indicated. We should just recognise that the document is out there, it exists, and we will now take it to the next stage in terms of what you do with that document. I think that's the point.
So this is an intent, that's why it's intention, so it's not actually the contract. So I think that's really important. So this is our local intent that we have with our providers, and I think it's important that we now go away and say, actually, this was our intention, and this is what we're actually going to do now, and this is what we will sign off in our contracts. But I think it does reflect certainly discussions that I've had at governing body level and in the management team. So I think that's right for South West London.
Do we have any other comments? Stephen.
I think just to confirm that, I think that although this document as such, we also haven't seen until this meeting, it is very consistent with quite a major concern that we've had, certainly in Wandsworth, for the last 2 or 3 years about the contracting rounds. So I do think it's a very important set of messages, actually, that I would I positively welcome the fact that they are being stated here. I do think it is consistent with, the concerns that we've had for quite a while. So I think it's quite valuable to have them stated fairly clearly in this sort of way, but recognise it is a direction of travel, not a sort of, this is the first word rather than the last word on this subject.
Right, we are asked to ratify the framework and the direction of travel. May I take it that each CCG agrees? Thank you very much. Thank you, Jonathan, and your team. We now reach the end of the agenda, and we come to questions from the public. I have had no questions in writing. Are there any from the floor? And this is on matters that have been on today's agenda. Okay. Thank you.
The term capacity has been mentioned several times at this meeting, in terms of mental health care and in terms of acute beds. I would ask the committee to think, if you're unsure of the demands now and ongoing into the future, you might actually consider stopping selling NHS land until you know for sure that you won't want it next year or in the next 10 years, because they're not making any more land. So I might suggest that you might consider stopping selling off my NHS land before you and we are happy with the capacity now and ongoing. But another point that you might consider is, given, as it's been released recently in the various AGMs, that you're failing to hit A&E targets, waiting times, you're failing to hit cancer targets, you're failing to hit ambulance waiting times, that you might actually consider, as caring doctors, with a first do no harm as your pledge when you become doctors, you might actually consider getting those things right before you start cutting, because that's all I've heard. It's all about rationalisation. It's about cuts. How can we spend less? How can we do less? And people are suffering. These aren't just figures that you're failing to hit. This is real people not getting the treatment we deserve and pay for and have built up over 70 years. Could you not consider getting those important things right before you consider cutting another thing? You are doctors. I count on you to look after us. And I might also say that when all these plans were being considered some years ago, and they were considering cutting acute services at Epsom, at St Helier, under BSBV, Chris Grayling, the then Secretary of State for Justice, advised people like you, who were considering at that meeting getting together and working as a committee in common. He actually advised the various board members to go home and take individual legal advice on whether or not you would be personally liable for the deaths that would result from your actions. Chris Grayling said that to the South West London grouping. I would advise you to consider it, because shortly after that meeting, BSBV fell apart. I would suggest that those board members took his advice to heart.
Thank you very much. Sarah.
So a lot of that is a statement, so I don't think it requires a response. But what I would say is, what I would say is that the CCGs do not hold capital or land, so are not selling off any land or capital because they don't actually hold any. On the demand and capacity, on the mental health, I think there's been a good piece of work done across London to understand the demand and capacity, and I think we do believe that the health-based places of safety will meet the demand. And as Tonya said, if they don't, then we will review that, because I think it's really important, particularly for mental health patients, that we have the right capacity in the right place. We've had lots of actually really good feedback from the police about accessing those services and how they have somewhere to take patients now where they will be seen quite quickly and they will get the right care. We would want to make sure that that continues, obviously, and I think it's a really important piece of work for us. So I think that's quite a positive piece of demand and capacity modelling.
Thank you.
If you thought it was reasonable to cut when people were dying as a result of lack of capacity.
As Sarah's pointed out, the CCGs don't own any land. Are there any other questions? Yes.
Right, it's a question I know I've asked before when I've seen Sarah at other CCG meetings. You've talked this evening quite a bit, I think, about integrated care systems. I'll spell out, my concern is about the development of accountable care organisations as a step on the way to transferring the NHS into a US-style insurance model. So my concern is about the link between ACOs and integrated care systems. I've been assured twice now that the integrated care system is nothing to do with the ACO. The reason I'm asking the question again, Sarah, is because I have a document here which is the risk and reward sharing for NHS integrated care systems produced by the NHS Strategy Unit. It was for the Commissioning Support Unit in Midlands and Lancashire, but the document is explicit in describing the parallels between accountable care organisations in the US and the integrated care system in the UK. And it talks about the development of the contract and how we can learn from them. I won't go into the detail, but I'm happy to at some point, but I'm just not convinced that this isn't what an integrated care system is leading us towards.
So, and as I've said before, an accountable care organisation is an organisation, an integrated care system, as described by the national team. To us is a partnership of organisations working across health and social care, and that's what we're working on locally in South West London. I don't know what the document is from the West Midlands. I'm sure we would love to learn from best practice, regardless of where it comes from, because my view is we want the absolute best care for our local populations, and we ought to learn from lots of different systems. But that does not necessarily translate into organisational structures, and what we haven't done in South West London is commit to any kind of organisational structures that deliver any kind of ACO, and we have not. And if we were going to do that, we would talk to the public about it anyway. And that's the same answer I know that I've given you in other meetings, and that is still the position.
I know you talk about the best care for patients, for learning from best practice for that. But what this document is all about is about learning the best way to transfer the risk to the providers, how you deal with the risk, whether it ends up, I mean, it talks about bankrupting.
So I'm sorry, I don't know what the document is, but it's not our document, and it's not something we're working on.
It's an NHS document, which
may
is
be,
why
but it's not to do with our agenda tonight.
It's not something that we are working on.
No.
Do we have any other questions on tonight's agenda?
Yes, Jonathan referred to extensive public consultation. Do you have numbers to indicate how extensive this was? And can you tell us how many people expressed support for your plans? And whether they actually signed to indicate that support? Where are these figures available?
So I think I was talking about, if I use the word consultation, that was an error. I think I used the words...
did I say consultation then? It was my mistake.
Okay, engagement.
I think you said engagement.
Yeah.
That's what I meant to say.
Yeah, so I think we've been trying to engage locally with people, and this is linked to local health and care plans and the work people are doing on those. I don't know the specific numbers. Colleagues may be able to tell us how many people have seen them in particular boroughs, but I know there's been many hundreds of patients who've been... Carol, you look like you want to...
Well, I know that there has been a great deal of engagement in all the boroughs. It's not the sort of thing... There's no one here from those teams this evening who could present this information, but there's certainly been plenty of discussion, particularly on each borough's plans, and there's been a lot of engagement, and it is still ongoing. It will
I'm
continue.
sorry, it's not satisfactory for you to sit there and use words like extensive, a lot of engagement, and you haven't got a clue as to the numbers involved. I've got a better idea than you have, because I've been to some of these meetings. There's been 2, 3, 4 people at most of them, and most of those people have been challenging what you're talking about, not indicating any acquiescence or support. I want to see some numbers, I want to see some signatures before you claim that the public support what you're doing.
So what we are doing is talking about children and young people mental health and trying to make sure we have the best care for them. What we're talking about is ensuring that we hit things like our A&E targets, that we have the best cancer care for our local population. It's what we do on a daily basis when we engage with the public in each of the CCGs. We talk to the health and wellbeing boards about what's our priorities going forward, how do we work together. This is not... These intentions are around what the CCGs do on a daily basis, around how they deliver care to their local populations. And I do
Sarah,
think
you're not talking about my question. I go to these meetings, I see that there's hardly any people there, I see no evidence of support, and yet you've got the nerve to sit there and say, oh, loads of engagement, loads of support.
I don't know
true.
what meetings you've been to around the commissioning
I've been to
intentions of children and young
meetings,
people mental
I've been to
health or
CCG.
those kind of things. You're talking about the Epsom St Helier work.
Engagement meetings that the CCGs have held recently, and one of the proposals was about having one acute
So these are about the Epsom St Helier. These commissioning intentions are not about Epsom St Helier specifically.
But then what engagements have you had?
I can give you an example, because I'm working on the cancer strategy for South West London, and I've just done 2 workshops over the last 2 months, and at each of those workshops for what we should do with cancer services across South West London, we had about 50 people to the first workshop and we had about 40 people to the second workshop. And then we're also going to do a survey based on the information that's come out of those workshops around whether people agree with all of the people that attended those workshops, what they were saying about cancer care across South West London.
The general public don't participate in workshops. They're not competent to.
We've had members of...
You're using the term workshop.
Yeah, we've had members. I'm just giving you an example of a piece of work that I'm working on, which is the cancer strategy, and I'm saying I can give you numbers because it was a recent workshop, and there were members of the public at those workshops.
What he was referring to when he said extensive engagement and support. What were you talking
I would imagine Jonathan is referring to.
So what I was referring to was that given the example that Claire's just given, it's just one example because cancer is one of the many areas I talked about. There is ongoing conversation with members of the public about, are these the right things, are these the right priorities? And the workshop that Claire was referring to, Claire and I were at yesterday, and there were a number of members of the public there, as well as cancer charities and other voluntary sector organisations. In addition, there will have been local engagement with patient groups as part of developing your commissioning intentions. And of course, members of the public will have every opportunity to go to any of the 6 governing bodies and input into this process. This process is not about the concerns that I know you have around services around Epsom St Helier.
No, that's not true. Our concern is about the entire NHS and the whole of South West London, and the plans that you are implementing are the same as everywhere else in the country. They're being tarted up as, with a pretense that it's to meet local needs. Nothing of the sort. There's nobody at these meetings in any numbers, and there's nobody in support. Your claim is bogus.
James.
So just specifically in relation to Merton, because I know that your interest is primarily Merton, I attended
it's not.
I attended a meeting.
Don't you tell us what our priorities are?
I attended a meeting that specifically discussed Merton CCG's commissioning intentions that was led by our Director of Commissioning, and I can't give you the precise numbers, I can get them to you afterwards, but there were at least 20 members of the public at that meeting.
And how many supported your plans?
It wasn't a meeting that was about securing specific support for a particular plan. It was about securing input and engagement around the whole range of things within the commissioning intentions. So I don't really think that's a valid way of characterising what the purpose of the event was. It was about looking at the full range of plans and getting some input during the early stage of their development.
I'm going to draw this meeting to a close now.
I've got another question, and I think you need to answer it. It's not time for the meeting to close yet. These questions were supposed to start at 6:15.
If your question is on today's agenda.
Yes, it is, absolutely.
Fine, thank you.
You talked about personal health budgets. What happens when a person continues to need health care and their budget is exhausted? When it's all spent up?
So a personal health budget is a way in which patients can take control of their own care, and they are set up with the agreement of the patient, and there is a very specific piece of work that we do with the patient carer and their family to make sure that they have more control over how their healthcare funding is spent, and there's lots of safeguards around that as well. And I know that personalisation, as it is called across the NHS, is seen as a very important part of how we support our local communities. We do it particularly in areas such as continuing healthcare, where somebody says, actually, I would like to be able to choose my carer. I'd like to be able to have a bit more control over my own care.
I don't want to hear all this. I want to hear what happens when a person needs care and their personal budget is exhausted.
So it doesn't work like that, because the person gets the budget that they need in order to get their care, and that's how personal health budgets work.
And a new health need arises, what happens then?
Then they will be reassessed and they'll get the support that they need.
There's no point in having a budget.
Well, it's about personal control and individuals having control over their own care.
Thank you very much. I think we'll call this meeting to a close
No,
now.
it's not time for it to finish yet.
We've finished the agenda.
I'm going to ask you to address some documents which clearly you haven't taken to heart. In the first 7 weeks of this year, for
Is
nothing
it to tonight's agenda, which is
Yes,
the
it's
subject?
about people dying, and tonight's agenda is about what's going to make people die. When
No, I'm
formerly they
sorry.
wouldn't
I'm
have.
sorry. I'm going to call this a close now.
Yeah, you don't want to hear some truths.